My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Hi, I'm Tiffany Carlson, a third-year medical student hailing from the Midwest, and you're listening to DO or Do Not. On today's episode of DO or Do Not, I interview Dr. Lawrence Sands. Dr. Sands has spent over 25 years working as a public health physician. He's led a variety of local and state-level teams in community health services, biodefense preparedness, and epidemiology. Dr. Sands is a board certified in general preventative medicine and public health. He received his Doctor of Osteopathic Medicine from the Chicago College of Osteopathic Medicine. He originally worked in his father's primary care practice in Michigan before going on to earn a Master of Public Health from the University of Michigan and complete a residency in preventative medicine and public health. Dr. Sands then earned a fellowship in clinical administration. Dr. Sands is currently the Vice Chair of the Department of Osteopathic Family and Community Medicine, Clinical Associate Professor at the Arizona College of Osteopathic Medicine, and Associate Professor in Public Health at Midwestern University. He has held various board positions to include past President of the Arizona Osteopathic Medical Association and the Adelante Healthcare as a board chairman. We hope you enjoy his story as an osteopathic medical practitioner focused on health policy, prevention, education, population health management, and addressing the social determinants of health and promoting health equity. Thanks for listening. Thank you, Dr. Sands, for joining us today on the DO or Do Not podcast. Really appreciate your time.
Great. Well, I'm glad to be here, and thank you for inviting me. I think this is terrific that you're doing this for students because one of the things I learned later after graduating and after internship and everything is that, there are a lot of different pathways, in medicine that they never talk to you about when you're going through medical school. So I think this is great that you're doing this.
Awesome. So I know that you have an atypical practice, but can you just kind of walk us through what you do on a daily basis?
Well, I teach now at Midwestern University at the Arizona College of Osteopathic Medicine. So my days here are different than when I was in a public health department. But a lot of my work is administrative, both here and there. But now we're doing a lot more teaching. But usually the days are, as described, it's a lot of blocking and tackling. Because you deal with, particularly when you're doing management and administration, you're making sure that things run smoothly and helping to solve problems and deal with, anywhere from personnel issues to budget issues to policy issues. So right now, as a vice chair for osteopathic family and community medicine, our big focus is always on rotations and preceptors, and because right now because of COVID, we have students that are coming on in and out of quarantine, and when they go into quarantine, then we have to come up with a plan about how they're going to continue continue forward and what work they'll do while they're in quarantine, while they're on the rotation, so they can meet the rotation requirements. So that's what's taking up a lot of time right now, with working with students both individually that way, as well as planning for rotations for the coming year when we start back again with rotations in June and July. So that's a lot of it. Today, we had some meeting with the dean and my department chair and one of our faculty who supervises our osteopathic scholars program, and talking about some doing some planning about some changes in that program in the next year. And then later after this, we have a chairs meeting that follows this. So we'll be all the department chairs will be meeting with the associate dean for clinical education, and we'll be dealing with issues that concern that we all share and help. And as I said before, much of what we're trying to do is make sure that students have rotation sites to go to, as well as that we have ways to continue to keep them moving forward in their program so that they can both complete the licensure examinations for Part 1 and Part 2 before they leave, and be able to graduate on time.
I like how you use the football analogy of blocking and tackling, because I think that is kind of what administration is to me. So puts it into perspective. So just going back to the beginning of your journey, when and how did you become interested in medicine and ultimately decide that you wanted to become a physician?
Well, I'll tell you my earliest experience or memory was back in kindergarten. And they give me the assignment, draw a picture of what you want to be or what you think you're going to want to be. And I drew a picture of me as a physician. So, and a lot of that had to do with that. I grew up in a physician family. My dad was an osteopathic physician, general practitioner, and had practiced for well over 30 years in Dearborn, Michigan. And also was a CCOM graduate. So DO is really all I really knew. I didn't really know there was a difference until later in life, but that's kind of how I, found, medicine as an interest, as well as, osteopathic medicine as a potential pathway in medicine.
So you're from the town where one of my favorite museums is. Growing up in Michigan, where did you decide to go to undergraduate? And then you alluded that you didn't know the difference between medicine and osteopathic medicine, but when did you make that decision to apply to CCOM?
Right. I went to the University of Michigan in Ann Arbor, and they have a very good pre-med program. And, it was never really a question. I mean, when it came time to take my MCATs and do my application, I applied. I did apply to both allopathic and osteopathic schools, but I really only applied to really one allopathic school, and that was Wayne State University, only because it was close by, and my brother was going there at the time, and I had a lot of friends that were going there, and really more for both the financial and factors, and and that was the only reason why I applied, as well as that it is a very good school and produces a lot of good physicians. But other than that, I applied only to osteopathic schools, and had my interview at Chicago when it was still in Hyde Park, and before there was a Midwestern University, and I got accepted right away, and there really was no question. I was excited to go to Chicago.
Yeah, so can you kind of, for posterity, talk about your experience at Hyde Park and just kind of what you did there during your time at CCOM?
Mostly study, a lot. Well, a couple things. My mother actually and her family lived in Hyde Park when my mom was growing up, before she met my dad and moved to Michigan. So it was kind of going home in some ways. I didn't have any family that still lived in Hyde Park. But at the time that I went to school there, it was the year that they opened up. The big news was the big outpatient clinic building next to the hospital. And that was a big deal, because up to that time, basically the family medicine clinic or the primary care clinic was in the hospital, and it was like a dispensary. It didn't have any real walls. And so you'd hear all these stories from the upperclassmen who had trained in that environment, as well as some of the faculty had trained there, and just some of the stories about just how different it was to practice there. So it was a big deal to actually have offices and individual exam rooms with real walls and doors and privacy, and as well as that they had a lot of different levels. They had the specialty clinics and the procedure room. So it was really exciting, because you were able to really get, at that time, this kind of state-of-the-art experience, exposure to medicine, in this new facility, which is great. And my understanding now is that building, which is well over 40 years old, was converted into condominiums, which I think is really kind of funny to think about today. But that's kind of the experience there. We had 100 students in my class. Pretty much within the first month, you pretty much knew everybody in the class. It was the same process as it is both at CCOM and here in ASCOM, where students are every Monday morning you have an exam on what you were supposed to learn the previous week. But I also just remember, having that kind of accessibility to the professors and the faculty there, and having much more of an intimate kind of experience, or small college experience, coming from a big public university where you'd be in lecture halls with anywhere from 300 to 600 students. That to be able to be someplace where you it's only 100 students and you're in a lecture hall and you pretty much know everybody knows everybody. It was a much greater sense of community, and that we're all in this together, and it was all about not no longer about getting into medical school. It was all about just graduating and helping everybody, and making helping each other make it to the end.
Yeah, that does seem to be the culture at CCOM. Where did you just do your clinical rotations at that clinic, or did you go to other places in Chicago during the clinical years?
Sure. Well, at that time I spent about, I think, 6 months in the family medicine clinic there, the way they had it set up, and then you did rotations through each of the different services in the hospital, and then you'd have some electives. But I did have the opportunity to go and to do my psych over at the Hinsdale VA, as well as to spend some time at the Rehab Institute of Chicago for physical medicine and rehabilitation, where there are a couple of the CCOM graduates were residents there, and that was really an interesting and exciting place to learn.
Yeah, and they still have elevator operators there too, which is kind of cool.
Oh, do they? Interesting. Wow.
Yeah. So, how did you ultimately decide on your specialty, and kind of walk us through that path, because it seems to be very eclectic?
Yeah, it was very eclectic. So, and what doesn't show up on my CV, but is that I came time for internship, because the whole internship, at that time when I graduated, you did an internship, and then you went into residency if you wanted to go on, into a specialty. And but most people did their internship, and that satisfied licensure requirements, and a lot of people just went into general practice or primary care. So at the time, my thoughts were I was either going to stay in Chicago, go back to Detroit, or I was going to choose someplace I really wanted to be. And I wanted to be someplace warm. So it came down to like Florida and Arizona. And I had been to Arizona before. I loved the state and the whole environment. I just loved the desert beauty. And I had spent, for my first year in medical school, spent a month at Phoenix General Hospital, shadowing, one of the docs there and his partners that my dad had known when he was a resident in Michigan when I was growing up. And so I got to experience more what goes on in a hospital, but also to learn more about Phoenix General, because that was something that I was, it was a potential for me to apply for internship. Had a really good experience, applied there, as well as to Detroit Osteopathic in Chicago. And at the end, when it finally came down to it, I chose to go to Phoenix, because I wanted to try wanted to get outside my bubble and experience the West. Before I had left Chicago, though, I did interview for residency at the Rehab Institute in Chicago, and was accepted. And so when I started my internship, I already knew where I was going to go afterwards. But during my internship, I really loved being in Phoenix. I really enjoyed the people at the hospital, had a really good experience. And so I was trying to find a way to stay there. That's something else that would take the place of going to back to Chicago. Ends up, long story short, I did go back for a month, but then during my internship, I also got exposed to ophthalmology, really got interested in that, applied for an ophthalmology residency, and then about a couple weeks after I got back to Chicago, at the Rehab Institute, I got a call to say that they had a place for an ophthalmology resident at the Pontiac Osteopathic Hospital at that time in Michigan. And I made the fateful decision to take that, and then spent a year doing that and realized that I just wasn't cut out to be a surgeon. And so at that time, I went into practice with my father in his practice in Dearborn for a couple of years. And during that time, I kind of assessed, like, well, what are some of my options and things I could do. One of the biggest influencers were during that time, that's in managed care was starting to become much more dominant in Michigan at that time. And we started experiencing the effects of that in our practice. And I made a decision that I'd much rather be on the policy-making side than on the policy-receiving side. And considered a lot of different paths, even going to like the business school. But what ended up happening is I ended up going to a CME program in Phoenix in February to get out of the snow and see some of my friends. But it was the American Osteopathic College of Occupational and Preventive Medicine. And it was there I came in contact with people and learned more about occupational and preventive medicine, and really learned that this is something that I was really interested in, because a lot of my practice, I focused more on prevention. I had more interest in prevention. And so after that, I began exploring that. And I discovered that the University of Michigan School of Public Health had a preventive medicine residency program. And so I applied to that, got accepted. The best part about that is that there are grants to train physicians to be in preventive medicine and public health. The focus of the program at the University of Michigan Public Health School was to train physicians to be, to work and stay in the local public health departments. And so the best part about that, because there was a grant, I actually got paid to go to school, and also, and they paid for my tuition. And the cherry on top of that was classes were only Monday through Thursday, so I can work Friday and Saturday, on the weekends and during breaks, so to make a little extra money. So it was a win-win-win all the way around from that. So that's kind of how I found myself into preventive medicine and public health, and I've been very happy with it ever since.
Not all of the students know what opportunities are out there for preventative med doctors. Can you just talk about your experience? And then maybe also with public health, you have a little zoology background. So how does that also inform your practice?
The zoology background? Well, zoology was as a major was really a convenience, because after you completed your pre-med requirements, you just needed one or two more classes to take to get the zoology degree. So it was really more of convenience. But I would say I think it influenced more though of how I looked at and my approach to osteopathic medicine, because I think when the last year in undergraduate I took a comparative anatomy course, and that informed a lot, because then when I got into our osteopathic manipulative medicine classes, I really kind of began to understand better what we were doing and how it's different from other kind of manual techniques, and that it's really applied biomechanics, which is what we were doing in the studying in the comparative anatomy course. So it did a lot to help inform that. The other part is just, it's just that it's more of that adaptive part of anatomy, that just like your body's anatomy shapes, form, and function in a lot of ways, and that the same thing with when you think about communities, how communities are structured, and everyone's structured a little bit differently. So maybe, some things work better in some communities than others, because of the way they're structured. There's a lot of the similarities that way, but on a much bigger macro level, if that makes any kind of sense to you.
Yeah, that does. So you finished your public health degree, and then what were your thought process in looking for that job after you finished?
My thought process was, my number one thought process was, I just wanted to get back to Arizona. Okay. To be really honest about it. I pretty much knew by the time I was in high school in Michigan that I was not going to stay in Michigan, and I just really enjoyed the community and and the environment in the West and in Arizona and the people that I worked with. But I was looking for something where I could really have an impact on policy, to be able to kind of work in a group that, much like a group practice, where you rely on each other, or you can learn from each other. And so, in other words, I knew that I didn't know everything I needed to know in public health, but I was looking for that opportunity to be able to practice and to learn as I went along, and have some mentorship along the way. And when I ended up finally applying to the Arizona Department of Health Services, where I had my first real full-time paid public health job, it was like that. It was like working in a group practice in a way, even though it was in a governmental agency. My boss who hired me, who was the division director and the state epidemiologist, he was an MD, MPH. There was one of the other people. We had an epidemiologist in our HIV/AIDS program at the time, which is, and you got to understand, this is the late '80s, so this is like very early on in the response to HIV/AIDS. He was also a public health physician. We had another public health physician who was working occupational and chronic disease control. The deputy director was a physician. So it's all this line. So it's like, it was really nice, even though it wasn't all medically. It wasn't a medical model as you would think about, like in a hospital or a clinic. But we all had different leadership roles within the agency for our particular areas, working with people who were epidemiologists or health educators or administrators or disease investigators, environmental health specialists, just a whole different variety of disciplines working together to achieve a particular goal. And so that experience was great. It was like kind of like my job was almost like running like a little local health department without actually having all the other issues with running a local health department, because much of what my area was doing was working with the local health departments and being able to organize a statewide program in coordination with the local health departments and be able to meet their needs in the particular areas that I had authority in.
Can you kind of share what's the difference between working at that state level and then going down to work at a county?
Well, I wouldn't say going down. They're definitely different. I'm very grateful for my experience at the state level and working in the state health department, which is also where I did my practicum. I did my practicum for my residency at a state health department in Indiana. So that's what I came with, and that's what I knew when I first started. Working at a local health department is really, I enjoyed the most. I liked local public health because you're so much closer to the people in your community. And you really get to learn about different aspects of a community that way, because you're not just working just with doctors' offices and hospitals, but you're working with the school district or school districts, as we have many of them here, just in the Phoenix area, but others, service agencies, nonprofits, voluntary organizations that all have a role in improving and protecting and promoting the health of the community. And so from that part, I just, it is definitely a different pace or different rhythm than working in a state health department. But it also helps, having worked at a state health department, to know this is how I need to interact. Here's where I can interact with the people of the state health department. Here's the things I know, the questions that I need to ask my state health department people, because I used to be one of them, and or understanding how what's driving their decisions, and so that helped to work better. The other part of it is, and just to be really blunt about it, is that at a state health, in working in state government, the budget is prepared by the governor's office with input from obviously all the agencies, but it has to get passed through a legislature. And so getting pay increases for yourself and for others is very challenging. So, and you'll read a lot, if you track this a lot in your own state, state government workers may go years without having any kind of pay increase or only very small incremental increases. The difference working for a county was, in our county, there were only 5 county commissioners or supervisors in our county. They only had to get 5 people to agree on the budget, and and you have a county manager and the health coordinator and all that. So it's a lot. So at the local level, salary increases and benefits at the local level improve much more quickly than they do at the state level in most cases.
Thank you for kind of explaining some of that. So now you are mostly academic and you've taught at many different institutions. Can you just kind of describe your experience in academia?
Sure. I recognized early on in my career that academia was definitely an option. Kind of like, when it came down to and looking for a job, it's either I can work for a state or local public health department, I can work for a health, some sort of health organization, particularly like a health plan or managed care plan, or hospital system, or in academia. I'm sure that there's other routes, but those are the 3 main things I was looking at. And so I always recognized that academics was something that I was interested in, and that I took whatever opportunity that was offered to me to either do faculty development or to be part of an academic or partner with an academic program, to do that, to start building that kind of academic portfolio. So I can get experience with that, but also with the idea that someday, I might want to transition into an academic position. And it helps to have shown that, that you prepared for that or that you have experience for that. So a lot of ways was, implicit to my job. It was often necessary to speak at conferences or small groups and prepare presentations to talk about things that are happening currently, in public health. So like right now, if I was still working in a state or local health department, I'd probably be having a talk every day about COVID or some aspect of COVID every day. So you do a lot of education in your job that way as well. And shaping, that based on, the particular audience that you're talking to. The other is that there are opportunities to do work. CDC has what's known as the Epidemic Intelligence Service Officer Program, which basically they're training largely physicians, but other health professionals in investigating outbreaks and training them in epidemiology. And many of them are often assigned to state and some local health departments for that program. So I've had people that have had to supervise that were in that program or in a supervised prevention specialists from CDC. And so you supervise it, you're also responsible for their, development in that. So you're doing education or mentoring there. The other is that the University of Arizona has a faculty development program, and so I was recommended for that one year by a colleague, and so I did that. CCOM has what's known as the Costin Institute, and so when that first was first initiated, I was in the first cohort with Dr. Nichols, who created the Costin Institute, and so that was another way for me to get more experience and understanding about what does it mean to be working in an academic setting. So so all those things, along with taking students as being a preceptor and taking students, and whether, DO students, MD students, I've had PA students, and when I worked in the public health department. All those things kind of build up, your kind of academic portfolio, as well as even volunteering to do admissions interviews, which I did at least a couple times a year when I was with the county health department here in the Phoenix area.
So you're our first physician that teaches at Arizona College. Can you just kind of highlight the Arizona school, and then maybe also talk about your new role with like the dual program MPH?
Sure. Well, the ASCOM, let's see, it's approaching I think it's 25th year since its inauguration. It's out here just northwest of downtown Phoenix in Glendale, Arizona, which is a suburb, much like Downers Grove is to Chicago. And we have about 250. They started out with 125 students, and around 2007, I believe, is when they increase enrollment to 250 students in each class. So now we have about 1,000 students on and off campus that we're educating here in Arizona. It's separately accredited from on its own. It's not an offshoot of CCOM. We don't necessarily share curriculum, we don't exactly have the exact same curriculum. We teach a lot of the same things, but how it's organized it may be a little different here. But we, I know that there's contact and discussion going on back and forth between both deans and some of the staff here with our CCOM counterparts. And students are, when they do their clinical rotations, we have several different regions. We have students assigned here in the Phoenix area, in what we call the East and West Valley areas. And we have cohorts, and then some of them are organizing cohorts around a particular hospital here in the Valley. We have a cohort of students in Tucson, as well as in LA and in San Diego. And then we have a cohort in Chicago, based in Swedish Covenant. And then I'm trying to remember what the last one is, I believe in Normal, Illinois. We have a few students there as well. So people are pretty spread out, certainly present a lot of challenges during the shutdown, but we made up with that with a lot of online teaching during that time, and we still continue to do that when necessary. What was that last part you asked about?
Just kind of asking for students as they make their decision about if they do a peer program or, some of them have dual degree programs. So just
Right.
Wanted to talk about what you're doing at Arizona with that.
Yeah. Okay. Yeah. Well, the dual degree, DO MPH program is really exciting. I'm really, excited that Midwestern, has started an MPH degree program, because I think it's something that I know that when I've done admissions interviews the last several years, usually I have at least 2 or 3 students, each year, or applicants each year ask about whether, Midwestern will ever offer an MPH degree program. And I think it is a big selling point for a lot of students that want to have a little bit more, want to have a bigger view of health beyond just, the medical model. So that program just got started last summer, and it covers both campuses. So we're working with students from both CCOM as well as ASCOM, but also we have students from dental and ophthalmology and veterinarian school as part of the program. We started out with 30 students in the first cohort, and we're going to be reviewing applications for the next cohort shortly. But the program is really intended for designed so that students can complete this during their 4 years of medical school or whatever program they're in, and where students can start the degree program once they're accepted into their primary program during the summer before they begin their primary program. So we had DO students that were going to start in the fall in 2020 who last summer started their MPH degree. And then next summer between first and second year, they'll take additional courses, and then they'll also complete a practicum and take some electives in order to complete their degree program. And then once they do that, then they will be able to graduate with both their DO degree and with their MPH degree at the same time. And I think that will give them a big leg up, hopefully both for residency, but also with whatever they decide to do in the future.
Looking back at all the things that you have done, what do you think is your proudest moment in your osteopathic journey?
Oh, yeah. Well, boy, I would say that I think the proudest thing is that early on was one of the things challenges that was assigned to me when I worked at the state health department here in Arizona was to update the state immunization school requirement law. And at that time, basically the law the way it was written, a parent can just write a note saying, yes, my child's immunized. And that would count for as in requirements of the law. So, but we had no idea, are they immunized against this or that or the other thing? And there weren't any specific requirements. So that was a 2-year effort and took a lot of working with a lot of different stakeholders and building a coalition. And at the end, we were able to get that stronger. And part of it was also there was a challenge that, from the schools that, they didn't want additional administrative requirements placed on them. And so working with my staff, we had to do a demonstration to show, that it would not require that much more work, or that basically, school staff were doing now to enforce a poorly written law, they would use the same efforts to enforce a more specific and better written law that had teeth. And so that has done a lot. Then that combined with organizing a statewide immunization coalition that still exists today independently. Those two things together, as well as getting a state immunization registry up and running, did so much to improve immunization rates for children of all ages and to reduce vaccine preventable diseases in Arizona. So that part I'm very proud of, that having to be a part of that.
I can't imagine just having a parent say, "Oh yeah, they're all immunized," and then they got flu and tetanus and no measles. So
right. It was what we call it, did not have any documentary proof. We just took people's words for it. And when I first arrived on the job, it was in the middle of a big pertussis outbreak, and that's all I did for 6 months was work on pertussis outbreaks.
So I'm just going to transition a little to some personal questions. You mentioned earlier that you were able to get a grant for your MPH. For your DO, did you take out loans, or how did you finance it? I think back then they had some state grants for CCOM. And then Since you're with students often now, do you have any advice for students in terms of financing and then choosing, their residency?
Yeah. Well, I would say for my residency, the school had Health Resources Service Administration administers these grants for training in preventive medicine residency. And so this University of Michigan School of Public Health had applied for that, and received that funding for that. So that's what they used, I guess, largely to recruit me. But basically that's how they funded my position and paid for my tuition, and as well as gave me a stipend. Medical school, the only time I took a loan off in medical school was after my first year. My mother had a very serious medical emergency, and did put a lot of strain on the family at the time. It made it hard for my dad to work because he had to look after my mom and stuff. It was on my initiative. I said, I took out a loan and paid for part of my medical school. For that time, tuition was high, but not as high as it is now. But I was paying that off in small amounts, and finally paid that out. But that was about the only time I took out a loan for medical school or any schooling. It's a much different landscape today for students, and I think the best thing for them is, really to talk to the financial aid people here, to, and come up with a plan that makes the most sense for them, and hopefully will minimize the amount of financial stress that it puts on them as well. My feeling with any kind of loan is I never like having to pay interest on interest or pay interest on taxes. So if anything, I would say always make sure that you're paying the interest, so that you're not paying interest on the interest, because it doesn't make sense to me. It just digs you down further into that financial hole. That's about the best I can say for that, from my experience. And but I think people have to decide for themselves what's really important for them and what they're most comfortable with. And investigate all the different options. Even a lot of students here do loans through the military, which is great because that gives you access to some great training later on, residency and so forth. I think people do really respect as well as admire people who have trained and served in the armed forces, and that they're valued later on for future employment. So that's something to think about. But also think about community health centers and the different National Health Service core loans, both either during medical school or for after medical school for loan repayment. There's a lot of benefits working in a community health center, and as well, it can be very gratifying for doing that. You may not make the same pay as you would if you were out on your own or in a private practice, but the other side of it is there are other things that you're not having to worry about, or that other expenses that are covered by a community health center position that would not be otherwise.
Thank you for walking us through some of the things that students can be thinking about with that, daunting financial investment. So we talked about this huge state immunization program. Can you tell us one thing about you that has made you successful throughout your career, as I like to call it? What is your superpower?
That's a good question. I would say persistence. It's the thing, they always say that that everybody recognizes people for all their successes, but people don't always remember that inventors like Thomas Edison, before he got the light bulb to work, he had a lot of failures. We don't talk about those. But the point is that you don't let those failures or things, bumps in the road, define who you are. There's just bumps in the road. Don't look at yourself as being the guy or gal like, oh gee, I'm the one that had to repeat this course, or I had to take part one of the boards 3 times before I passed. It's like, that doesn't define you. That's just a bump. Your patients aren't going to know that necessarily unless you tell them. But again, don't let that keep you from being persistent and keep moving forward towards your goal. And I think that's what's always helped me, is not to be defined by those bumps in the road as much as by where I'm at now and what I'm trying to do.
Yeah, not letting you be defined by failures and just pushing forward. So I'm going to touch the third rail about work life and family balance. You just talk about how you balance career and family, and then what are your hobbies?
Sure. I think the thing is you just intentionally have to, you make time for doing that. My feeling is that, when I'm at work, I'm at work. When I'm at home, I'm at home. I got, started having kids and, being a new father. It's like, went through that period where, when you're at home, you're thinking about work, and when you're at work, you're thinking about home. And, you have to get out of that after a while. And so my feeling is that was my boundary. When I'm at work, I'm at work, and when I'm home, I'm at home. And, I try not let the two intersect too much or as more than necessary. But that was much harder to do when I was, a health officer and I was the head of an agency. But you try to carve out those times, where it's like, this is my time to me. Right now, travel is a big thing. I wish I could do it right now because of, it's not possible because of COVID. But we, definitely love to travel, taking some really great trips, want to be more adventurous. But also, my wife and I have gone into, one of the other faculty members here that I'm friends with, they turned us on to going up to Sonoma in Northern California into wine country. And so we're really into wine now and really enjoy that. And then most recently, we've gotten into playing pickleball. So that's kind of like the big thing to do out here right now. And talking to other people, friends elsewhere, that people are doing that elsewhere as well. So those are kind of the things that right now are keeping me occupied outside of work.
Yeah, they've actually taken out some tennis courts and added pickleball courts in some places around here. So I've heard, heard that as well. So with this idea of like biomechanics, and just to close us off about OMM, is there any connection with osteopathic medicine in public health and then use for OMM in that arena?
I would say more the principle, okay? And I always say is that I compare one of the tenets of osteopathic medicine to the mission of public health. The mission of public health is to ensure the conditions in which people can be healthy. And when you look at osteopathic medicine, our role as physicians is to create the conditions in which the body can heal itself. To me, that's, those go together very well. That, it's not always about trying to find the disease and just fixing disease and injuries. It's like the quote from Still is like, finding disease is easy. You want to find health. And, that's what I'm trying to do in public health, is really focus more on how do we create the conditions for wellness and help people stay well as to return people back to wellness if they fall out of wellness. So I think that's where I see the connections, is really more from that philosophical approach between osteopathic medicine and then the mission of public health.
That makes sense. So I know you have to get back to blocking and tackling with your committee meetings this afternoon, but just want to thank you for your time, and then close up with, what was the best piece of advice that you got throughout your journey? It can be from growing up, college, medical school, residency, even, in the health department, that you always think of and would like to pass on to our pre-med and medical students?
I think that the one thing I think about is someone I had worked with, an executive coach for a short time a while back. And one of the things, he said to me that, as he's kind of assessing, where I'm at and kind of my orientation was, he said, it's like, you should play to win. Because what he was saying is that I was trying to play things safe, playing not to get hurt. And that doesn't work, say, if you're playing a ball game. You want to play to win. So it doesn't mean that you take unreasonable risks, but it's more that orientation of like, what do I need to do to get to what I really want, to get the outcome I really need to achieve, versus thinking about how do I do this without getting hurt. So, and I think when we had that discussion, I think that really kind of changed kind of how I looked at things, and then to change how I approached my work.
I can definitely say that you play to win. So thank you so much for coming on the Do or Do Not podcast. Really appreciate your time.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.